Everyone. I'm Kirsten Miller. I'm a pediatrician in Prince George, and I'm involved in organizing this conference with Aben and Kelly as well. So I'm going to introduce Dr. Curren Warf, who will be speaking next. Dr. Warf, most of you I think know, is the head of the Division of Adolescent Health and Medicine and a clinical professor of pediatrics at BC Children's Hospital and UBC. And he came here from Los Angeles in 2009, was on staff there for 15 years as head of the Division of Adolescent Medicine there, and has established or helped to establish the new adolescent medicine subspecialty training program here in Vancouver. So go ahead, Dr. Warf.
Hi. Well, actually, I was not the head of adolescent medicine in LA. I was the head of the fellowship program and the high-risk youth program. So through the high-risk youth program, I dealt with many, many young people on the streets in desperate situations who had various levels of drug use. And I may tell a few stories about that in the course of this presentation. I just wanted to just give a little personal note also. I'm a child of the 60s. I was a teenager in the 1960s. I hitchhiked around California. I grew up in LA, and I smoked pot. I have to confess, I smoke pot, okay? And one of my first, maybe not the first, but one of my first issues of social justice was the terrible oppression of teenagers by the illegalization of pot. And that I felt passionately that marijuana needed to be legal, and it was irrational that alcohol could be legal and marijuana could not, and it was just unfair. So, and here we are. Marijuana is on the cusp of being legal, and I'm no longer a teenager, and I missed out. So it got me thinking, because since I've come up here, well, actually prior to coming up here, but particularly since coming to Vancouver, I've encountered a lot of teens who actually marijuana is not a benign experience. And I'm sure as pediatricians, you've seen this as well. And it's had me challenge some of my own ideas and my own youthful beliefs. And in the end, I still believe marijuana should be legal, but I believe in the same way that I think beer should be legal, or wine should be legal, or bourbon should be legal, not because it's harmless, but because making it illegal does no good at all in terms of reducing use or addressing health issues. And we'll get to that in a second, too. I'm going to talk a little bit also about some historical background about marijuana that is interesting. Some of the, from the standpoint of a pediatrician and from the standpoint of an adolescent medicine doctor, I am very concerned, obviously, about the health of babies and the use of marijuana by teenage mothers and by adult mothers or adult pregnant women, and the potential long-term consequences for their offspring. There's also, we have actually had medical marijuana before we have legal marijuana. And I know you've run into this too, and I'll have a few comments about that, about what research we have. The effects that marijuana can have on the lives of adolescents, some questions about its potential addictiveness, on the neurologic effects of marijuana, and on questions of safety about recreational use. And finally, some ideas based on the research that exists on effective approaches towards primary prevention and early intervention and intervention when there's more significant drug use. We have had shifting attitudes towards marijuana and towards drugs over the years. These are frequently not particularly determined by the actual effects of the drugs or their risks, but they're frequently due to the cultural values in the society that they arise from. There was drugs, in particular opium, but also marijuana, have had a significant impact on our history and the history in Asia, the history of English imperialism, the history of American colonialism, and colonialism of the Americas. In fact, the illegality, marijuana and cannabis was not even illegal during this time when it was imported directly. There have been various perspectives on it based on its strength. Marijuana has been around for thousands of years, and more recently, it has become increasingly concentrated and increasingly able to cause physiologic disruption. It's also been involved the illegal trade of marijuana and the illegal trade of alcohol is really what created the mafia, what financed organized crime in Canada and the United States, and we are still living with the consequences of that. Mexico is also living with the consequences of that today, and I'm sure you've read the papers. Marijuana has been tracked back about 12,000 years to Central Asia, which appears to be where it evolved and developed. There was a first record of medical use of marijuana was over about 4,000 years ago, almost 5,000 years ago in China, when it was used as an anesthetic for minor surgical procedures. There were historic religious uses of it, and notes in China that it produced hallucinations, that it makes one able to communicate with spirits and enlightens one's body. These weren't considered bad things. These weren't reasons not to use it. These were reasons to use it, really, because it broadened your connection with the spiritual world. It was sometimes in China, it was seen as a threat, that it was destabilizing for society and it was suppressed. But at other times, particularly with the British and the Portuguese during the slave trade, marijuana was felt that it was pacifying, that it would keep the people that they were selling quiet and non-rebellious. And it was actually promoted in its use. It was brought to the New World. It was brought to the Caribbean and South America separately, but both through the same slave trade. It was a very late introduction to the Americas, really not until the 19th century. And it was not even introduced, it was not introduced to North America by then. It took about 100 years for that to occur. This is a map of its diffusion of marijuana throughout the world, initially in Central Asia, being cultivated 12,000 years ago, or 12,000 BC, 14,000 years ago, and not moving from Asia directly to the New World, but going through the Middle East, through Africa, through Europe, and finally being taken by the Portuguese and British colonialists to the New World. You can see that it went up through Central America, and it was only brought to the United States after the Mexican Revolution in 1910. And prior to that, the United States was really naive to marijuana. And it was quickly accepted by musicians, by other creative people, and by many of the refugees and immigrants from Mexico. It was largely because of just an artifact of the populations that were using it in the mid-century United States. It was tied to racist ideas about African Americans and Latinos, and that endured for some time until the 1960s when college students started taking it up. And it was considered as part of the youth culture. It was integrated into by Allen Ginsberg and Jack Kerouac and other people in the Beat Generation as part of the literature and the culture of the 1950s. And here we are now, where we are now promoting it as medicine. And we are on the cusp of legalization in Canada. And we have, what does this mean for young people? And if you're more interested, I find this historical piece very interesting myself. There's an article written by Dr. Warf, but not by me, by my brother, who's a geographer. So if you want a very interesting on the social history of marijuana, it's a great article. It's in the references here somewhere. So just a few comments on what does it mean to be, what about legalization versus medicalization, okay? So one of the dilemmas that I have is that with young people, when we talk about medical marijuana, implicit in their naive thinking is that's safe marijuana. It's safe. Otherwise, why would it be medicine otherwise? I can take it for the things that bother me. Well, all kinds of things bother me, like stress. I get stressed, so I need to use some marijuana. I get stressed again, I need to use it again. And if I get stressed several times a day, maybe I can avoid stress by using marijuana several times a day. Maybe you've encountered this with some teenagers. And before you know it, they are using it regularly in a pattern. And, you know, and what happens is then if they don't use it, why they feel stressed. They can't sleep. So they need to use it. Right? And what they're really experiencing is withdrawal symptoms. But in their mind, they're very naive, and they feel that this is really their failure to use this medical marijuana. This is a very different model than talking about legalization. Where alcohol is legal, we don't talk about you have to have your bourbon 3 or 4 times a day, or you don't have to have your bourbon every time you're stressed. We can talk about you have your bourbon or your beer or your wine or whatever with your friends occasionally. You don't drink when you're pregnant. You don't drink when you're driving. You don't drink when it interferes with your work. You don't drink when it interferes with school. And these are very reasonable limitations to put on that everybody can understand. So we might want to shift our thinking in terms of how do we culturally view this, much as other societies have shifted their views. There are other unintended or perhaps intended consequences of having marijuana illegal. For example, in the United States, it's a Schedule I narcotic. It's illegal under all circumstances, federally. It means their research is illegal. So we have, despite 100 years or more of use, widespread use in society, being the most common illegal substance used by teenagers, we have very little research on its actual effects that have emerged over the last 50 or 60 years, most of which has been in the last 5 or 10 years. It also means that marijuana now and marijuana possession is the most common crime that adolescents commit. And it is more common than all violent crime put together. So despite what you see on your television shows with the graphic violence, in fact, the crimes that are committed are much more mundane. Possession of marijuana, for example. It is also, as I mentioned, it leads to, as long as it's illegal, the people who sell it are taking chances, taking risks, they distribute it, they accrue a great deal of profit and monies. And so I think I will skip that. So marijuana is now the 3rd most popular recreational drug after alcohol and after tobacco. It is actually more common among teenagers in Canada than tobacco use today. So it has hallmarks that are not too dissimilar from the religious comments that I made before of euphoria, relaxation, perceptual alterations, time distortion, appetite inducement, and intensification of ordinary sensory experiences. I'm saying this not because I don't think you know this, but because I think maybe none of you have ever tried marijuana yourself and are maybe unacquainted with the effects. So the concentration of THC in marijuana has increased dramatically from about 4% in 1980 to about 12% in 2012. And this is just that which is routinely grown and dried and smoked. This is not specially prepared. We also have means of preparing now which are different than we've had in the past, extraction of oils, which can be transmitted through the skin, and hashish concentrations with as much as 30% by weight of THC. So it can be extremely potent. We also have different means of ingestion. Rather than just smoking marijuana cigarettes, we can also use water pipes, which you should know, even though the motivation for using water pipes among young people is commonly because they feel that it's safer and that they're not going to get the smoke in their lungs. The reality is absolutely no safer than smoking the straight cigarette. We can have oral ingestion and vaporizers, which are, in fact, from a harm reduction standpoint, probably the safest way for people to smoke something. Because it does not combust the plant, but only vaporizes or volatilizes the THC, so it can be more or less purely inhaled. There are other now synthetic forms as well, which I'll talk about in a second: Marinol, Sesamet, Sativex, which have some very narrowly prescribed reasons for use. These are extremely potent drugs. It is essentially pure THC and has various means of delivery. Our understanding of the neurophysiology and the physiology behind marijuana on the human body and its dangers for fetal development and the dangers for adolescent neurodevelopment and its role in addiction is not so different than how our understanding has come from other drugs that are derived from plants. For example, opiates, and the whole world of opiates started with the poppy. And the poppy and opium was around for thousands of years before the actual physiology and actually that human beings, this is a future pediatrician here. The opium poppy, the human body has in fact specific opiate receptors for which are ligands for the chemical produced by the opium poppy. Much as the human body has prostaglandin receptors that were discovered through the discovery of aspirin, and in fact, something that develops in a completely unrelated species is able to affect. It's very interesting. It's very interesting how integrated we are as a species. And we find after the discovery, after the use of marijuana and the working through the neurochemistry of it, that there are actual cannabinoid receptors, several types, that are distributed throughout the human body, largely in the brain, but in other tissues as well, that play some kind of physiologic role in our own development. There are, I think I've gone through this. So they are distributed through the brain, largely in those parts of the brains that regulate mood, that are involved in addiction, and also in the prefrontal cortex. They're also, interestingly, in lymph tissue and in some immune system cells. So there may be roles for cannabinoids in areas that are yet to be elucidated, that we really don't know yet. So one place to start in looking at why is this relevant for pediatricians is to look at, well, what is the effect during pregnancy, and what do we know about that? I grew up thinking marijuana was benign and safe, as do most people. But it turns out that maybe it's not quite so benign. We know that somewhere from 2 to 5% of pregnant women smoke marijuana. This is by disclosure. The number is probably somewhat higher than that. We know that that is in the general population, but among young, urban, low socioeconomic status women, 15 to 28% smoke marijuana during their pregnancy. It's like 1 in 4. Those that use, once they discover that they're pregnant, 34 to 60% continue to use, knowing that they're pregnant. And about almost 20% of those pregnant users meet criteria for marijuana abuse or dependence. Most of those women, like 90% of those women, feel that it's safe. So there's no real reason to stop or reduce use. This is just a graph looking at the prevalence of marijuana use in the last month for the years 2002 through 2015 by different age groups. Those that are pregnant are in the blue bar. Those that are not pregnant are in the olive bar. And the youngest group, from 12 to 17, of pregnant women, make up the highest proportion of those girls are those who continue to use. So this is an especially pertinent issue for those of us who deal with pregnant teens and also for other older women who may feel that they are ingesting a harmless substance. We know that fetal brains develop endocannabinoid receptors as early as 14 weeks in gestation. So we know that they have the capacity to be affected by cannabis. We know that in fetal brain development, and we know this through studies of mice and rat brains, and other mammalian species who have very similar neurophysiology as humans, that they play a role in the neural migration during fetal brain development. We know that that animal studies where we can deliberately introduce cannabis into pregnant mice and pregnant rats, we can demonstrate disruption of normal fetal brain development. We know that high levels of cannabis potentiate the effects of alcohol on the fetal brain, potentiate it to the effect that the neurons die more readily when they are simultaneously exposed to cannabis. So I'm raising this again as, we have had campaigns in Canada and in the United States around drinking alcohol when one is pregnant or potentially pregnant. And we have not had any similar campaigns about cannabis. And we have evidence that it has a similar effect. THC is a lipophilic molecule, and it crosses the placenta. In occasional users of marijuana, that is once a week or less, about 10%, they have fetal levels are about 10% that of the adult. But in chronic users, that is those who smoke more than once a week, the levels are about 30% those of the adult. So they're substantive in the fetal blood. THC is also secreted in breast milk, okay? And it is absorbed by the fetus. And, the brain development doesn't stop at birth, okay? It continues. So we don't really have solid evidence on what, if any, effect continued exposure every day, every meal by infants has. But I think we have to presume harm given what we know from animal studies. So the use of marijuana by breastfeeding mothers is something that I think is kind of an unacknowledged danger. THC, the studies on this are sometimes confusing because the same people who are using THC or marijuana are commonly drinking alcohol and also smoking cigarettes, both of which have toxic effects on fetal development. And there's also some problems with bias of recall for the study. So one should not be too overly confident in the accuracy of these, but there have been several longitudinal studies, which I'll get into in a second, looking at infant development and child development of those infants who were exposed as fetuses to cannabis over a 20-year period now, so we can see what the development is as they become adolescents. One is that there is no known effect on perinatal mortality, so these infants are not more likely to die. It is the effects on head circumference, effects on low birth weight are variable, and the studies do not have consistent signs of that. The preterm delivery and small head circumference do seem to be correlated by those people who smoke both cigarettes and cannabis, and that's a fairly consistent finding. There's also some neonatal behaviors, sleep disruptions, increased startle reflexes on newborn babies after birth when they're apparently experiencing withdrawal. There's been, as I said, 2 longitudinal studies, one done in Ottawa and one done through in the United States in Pittsburgh. And those show that by age 5 or 6, there were worse visual problems and visual problem solving, short-term memory deficits, and increased impulsivity and increased hyperactivity among those children who had been exposed in utero to cannabis. By age 9 or 10, there was a persistence of rates of hyperactivity, of inattention and impulsivity. However, the formal IQ testing seemed to not be affected. And by adolescent and young adulthood, there were deficits in executive function, that is, in the flexibility of cognition, in sustaining attention and working memory. So these effects, these fetal effects, seem to persist at some level. And this is, what is picked up by formal testing. So one has to also acknowledge the limits of that. So the conclusions is that cannabis during, this is from ACOG actually, which I should have noted, is that cannabis use during pregnancy should be as significant as alcohol or tobacco use and should be discouraged. There's little data on marijuana use during lactation, on its effect on human infant development, though breastfeeding mothers who use marijuana expose their infants to THC. And medical marijuana in particular, which you might be able to provide, should not be provided during pregnancy or childbearing. So there is an excellent report by ACOG on this. There's two excellent reports, one on the longitudinal studies and one on their recommendations for pregnant women that I just wanted to draw your attention to. What about medical marijuana? Well, as I mentioned, we have the endocannabinoids are present, have effects throughout the body. And we have some reasonably good studies under some conditions that show a positive effect under very narrowly prescribed conditions. One is for spasticity with multiple sclerosis. This is not typically a condition that we see during adolescence. We do rarely, but it's much more of an adult issue. Cancer pain and with Sativex and chemotherapy as an antiemetic. Those are the only conditions under which there is research showing a positive effect. Okay. I was convinced of this myself for medical marijuana. I had a good friend of mine in Los Angeles who developed ovarian cancer in her 40s and underwent chemotherapy and ended up experiencing a lot of pain. She hated narcotics. She was not a druggie. And she felt, it's not the double-blind studies, it's these personal encounters that really, for me, end up influencing my appreciation for effect. She felt the only thing that really helped her was the marijuana, was her pain control. And she's dead now from this, but I do sense, and not only this case, but from other encounters, and I think from the studies, I think there's very convincing evidence for some use of this for neuropathic pain. Again, for chemotherapy patients, for increase of appetite, chronic neuropathic pain, there is some argument to be made. The only formal study that's really been done is on multiple sclerosis. And there have been other studies done for things like anorexia nervosa. Everybody knows you smoke pot, you get the munchies. Does it work? No. Okay. What about Tourette's syndrome? No. What about irritable bowel syndrome? No. What about anxiety? No. In fact, I would offer, based on my narrow, unscientific evidence, that it ultimately worsens anxiety. What about PTSD, which has been promoted for, particularly in the United States with the vets? No. What about epilepsy? No clear evidence, it's questionable evidence with infantile seizures that maybe bear as a last line if all else fails, intervention. Parkinson's disease, no. Glaucoma, no. So there's also, I guess, on the good side, there's no known association with lung cancer. So those are the medical effects. The marijuana, smoked marijuana, has pretty much, in addition to the THC, has the same kind of chemical makeup as exists in tobacco, besides the nicotine, that are carcinogenic and can cause be related to COPD. And it seems to be mainly because the frequency of use of marijuana is much less than the frequency of use for cigarettes, which cigarettes may be 20 cigarettes a day, marijuana may be a joint a day. And it may not be because of the qualitative difference in natural plant substances that are combusted. According to medicalmarijuana.ca, and I went online, I found out all they're calling me a liar, okay? All these are, and I will bore you and read them. ADHD, Alzheimer's disease, if only. Anxiety, arthritis, auto accidents, back and neck problems, brain injury, cancer, chronic nausea, chronic pain, colitis, depression, eating disorders, epilepsy, fibromyalgia, gastrointestinal disorders, hepatitis C, HIV and AIDS, irritable bowel, kidney failure, dialysis, migraines, multiple sclerosis, muscle spasms, muscular dystrophy, Parkinson's disease, PTSD, severe arthritis, sexual dysfunction, sleep disorders, spinal cord injury, and Crohn's disease. And if you don't believe me, here's the shop is testimony to the efficacy and its utilization for this. Now, I know, because I know from the testimony of my adolescent patients, that even though you need somebody to prescribe this, the way you get a prescription is you go into this shop and you say, I have stress, I need marijuana, I have blah, 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 I want marijuana. They have somebody they can call and say, Joe here has stress, he needs some marijuana. And I'll say, okay, here's some medical marijuana. And so the level of evaluation is like that, okay? So I'm not saying that's true for every one of these shops that we all see, but I do know that this is true for some of them. So as long as we have this level of availability, it seems to me making it legal just makes sense. So, well, what are the real adverse responses? Impaired short-term memory, decreased concentration, decreased attention span, decreased problem solving, and ultimately school failure. Alterations in motor control, judgment, reaction time, tracking ability, higher rates of mental health disorders. One thing I found out in preparing this presentation was that 25% of new onset psychoses, it's 1 in 4 sets of new onset psychosis are related to high potency recreational marijuana use. Okay, so the next time you see a kid hearing voices, this is something high on the list of your differential. Cannabis hyperemesis syndrome, which I'm not going to talk much about today. There is some evidence of increased automobile accidents, lethal automobile accidents. The evidence is fairly thin, but it's not intuitively seems reasonable. It's out of a Colorado study of the rates of adolescents involved in lethal automobile accidents before legalization and after legalization and their THC uses. And there's also the passive effects of marijuana smoke that maybe expose children and other people in the home. We should also think of not just the biomedical effects, but the effects on, what is meaningful in the lives of young people. Kids who, and you may have encountered this, kids who are into the marijuana use constantly end up retreating into their bedroom, withdraw from the family participation, sometimes withdraw from school, like play video games, if that, and are not capable really of having a job. A lot of family conflict commonly develops around this as parents struggle to get their kids back involved, commonly failing, and estrangement develops between parents and their children. There's sometimes kids and sometimes adults, frankly, who are really into the marijuana will smoke regardless of who's around. It feels that there's right. So there may be younger siblings to which their older siblings are modeling this behavior, or parents sometimes are modeling behavior. And then, of course, there's the activities they may be involved with if they're driving or involved in other potentially dangerous activities while they're stoned. What should we look for? One, and this is look for in terms of not so much whether you're going to pick up every kid who smokes pot. That's not the point. The point is whose life is being affected by this and what are triggers for this. One is younger age. So the information, the data is that those kids who start before age 15 have higher risk of developing actual cannabis use disorders as later adolescents and adults. The key marker, and commonly this is maybe what stimulates parents to bring their kids in, is that despite the negative consequences, despite not being able to go to school, but despite not being able to do their homework, despite all the conflict with the home, despite their withdrawal from other activities, they continue to use. And this is the same thing you see with alcoholics, really. That the need for escalating amounts over time. And sometimes the marijuana occurs alone, which is actually, I see more frequently than not, but sometimes it's not alone, and sometimes it's in the context of other substance abuse. So there may be multiple challenges clinically that may be very difficult and very complex to try to address. Even identifying the problem sometimes is difficult. DSM-5, and I will just go through this very quickly. You're maybe familiar with most of this. Provides criteria of cannabis use disorder, and it means taking larger amounts for longer than intended, wanting to cut down on the cannabis use but not being able to, spending a lot of time getting, using, or recovering from use, cravings and urges to use, not managing to do what you should do at home or school or work due to substance use, continuing to use even when it causes problems in your personal relationships, giving up important social, occupational, recreational activities because of substance use, using substances repeatedly even when it puts you in danger, continuing to use even when you know you have a physical or psychological problem that could have been caused by or made worse by this substance, needing more of a substance to get the same effect that you want, and the development of withdrawal symptoms, which can be relieved by taking more. So these are, I think, familiar signs to those of us who work with young people or adults really who use drugs, but it's important that the same criteria that we use for other substances that we commonly recognize kids are adults and adults as well experience addiction, we use for marijuana as well. So one thing that I see and I recognize, maybe I see more, or maybe I recognize more, I don't know, is the cannabis withdrawal. I kind of grew up not believing it really existed, but I am a believer now that kids actually do have cannabis withdrawal that is authentic and genuine. And they don't recognize it. They view it as they're stressed. They view it as they're anxious, that they've got a mood problem. But in reality, that they have commonly a sleep problem. I can't sleep unless I smoke marijuana. And what in fact this usually happens is they've been smoking for a while and they're trying to cut back. And they felt that they're doing a bit too much, or they've told by their parents or told by the doctor to cut back or whatever. And they genuinely can't sleep. And what relieves them is the smoking of the marijuana. That they get restless or nervous. They get depressed if they don't smoke marijuana. So these things that they may view as symptoms of treating, in fact, are the signs of withdrawal. As you know, that fetal brain that develops during fetal period in an early child continues to develop into adolescence and into adulthood. We now have very good studies tracking children from age 2 to age 24 with functional MRIs and other studies looking at their development. There's a few key points. I'm not going to dwell on this for too long, but there's a few key points. One is that the parts of the brain that are latest to evolve are the latest to mature. So those areas that were earliest to evolve, our sense of smell, hearing, etc., those are evolved very early in life. But the later parts to evolve, particularly the frontal cortex, that makes the human species unique among other mammals, and our ability to think and conceptualize abstractly and plan for the future. Those parts tend to mature later than the rest of our brain, including those that generate emotions and feelings and passions, and our ability to inhibit those, our behaviors related to those passions, is also late to mature. These studies, this particular study, I think, is of about 800 children that were followed for, I think, 20 years with periodic MRIs. And brains are very different from individual to individual. It mushes all this information together. And what you lose with this tracking is that, in fact, some kids' brains seem to mature fairly early. And they become, and we see that in our experience, that there's these 18-year-olds behaving like adults. And others seem to be delayed. And you probably see this with 40-year-old men who behave like they're 15. So we have a little video here that is dramatic about this, if that works. It doesn't look like, no, it doesn't look like I'm going to get it. So I think, anyway, it dramatizes this, but I don't think it's going to function on this. Okay. This is a cartoon just to demonstrate some of the deeper brain structures, the amygdala, the basal ganglia. These are very interesting structures that are not so readily visible on these functional MRI studies, but are areas where most of the cannabinoid receptors are located. Though they are dispersed in other parts of the brain, they are really focused in the basal ganglia. The basal ganglia is instrumental to the development of addiction and withdrawal for all drugs through similar chemical pathways. Some stimulate more strongly than others. Marijuana certainly is not the strongest of them, but it does have an effect. Our understanding of this has exploded over the last 10 or 12 years with very good studies looking at the anatomic and biophysiologic effects of drugs. We've also had animal studies, as I mentioned earlier, where we even, mice have adolescence too. I'm out of time. Okay. So I'm out of time, and I will drop the brain stuff. What I would like to do is just leave you with two thoughts. Can I leave two thoughts? One thought is there a recreational use for marijuana that's safe? And one is not if they're at risk for pregnancy, not if they're driving a car, not on school days, not if it interferes with other activities, not as a sleep aid, not before they're 16, never a synthetic. And beware nowadays with contamination with fentanyl. It's in the street marijuana. And it really is a cry for young people to have more of connection with their families and more meaningful activities in their life. And I have some nice stuff here, but somebody has to do something about it. It's just incredibly pathetic that it has to be us. And that is by Jerry Garcia, who was from the Grateful Dead, who I love the Grateful Dead, but Jerry Garcia died from a heroin overdose. So I skipped out on some of the prevention stuff, but I think, yeah, it's a picture.
If you've gone over time, we'll probably have time for we'll take a question. I was just wondering, if you don't mind, for the teenagers they think they're treating their anxiety or depression by smoking pot several times a day, how do you get around that conversation where they definitely feel improvement in their symptoms when they smoke, and it makes them function?
Yeah. So I would say that there's something called motivational interviewing, which is a fairly easily learned practice that can be done in clinical encounters with adolescents. In your clinical visit, it doesn't take a lot of time. Okay, it's not a thorough history. But what it does is it elucidates from them what they get out of it, and you validate that. You don't challenge it. You just accept and you hear what they get out of it, and you can kind of pull that out of them. And what problems do they have? Maybe it's the sleep problems. Maybe it's problems with their parents. Maybe, oh my God, I'll get arrested. You validate that too, and you repeat back that, and you try to emphasize some of the potential problems that they may have that they've already voiced. And so you raise that more, and you try to create a motivation for them or help enhance a motivation for them to change. There is good data that motivational interviewing with marijuana abusing adolescents and other drug abusing adolescents works sometimes, not all the time. I think with some kids, truthfully, I think the best line is prevention, which I should have talked about. But the other piece is I don't think we really have adequate resources for this for the kids who are really entrenched in drug abuse. And that particularly for the young kids who are 14, 15, 16, not going to school, their developmental needs are not being addressed. I really do believe we need to have a much more forceful approach in interrupting this activity. And I would advocate for secure care for these kids to get them out of the family, out of the school, interrupt their drug abuse, and not make it dependent on the Mental Health Act. Okay? So I think it requires some legislative changes in BC. But I think as we know more about this, I think we need to take it more seriously. But that would be my suggestion. We're not really equipped as the province here to deal with it. And we will continue to have problems. So.
On behalf of everyone.